Good
Today,
evening.
my topic is anesthesia for thymectomy for myasthenia gravis patients. Uh, I'll give a little bit elaborate on myasthenia gravis also, sir. So, myasthenia gravis, it's a chronic autoimmune disorder at the neuromuscular junction. It is usually associated with other autoimmune disorders also. Here, the pathophysiology lies due to the autoantibodies against the nicotinic type of acetylcholine receptor, especially the skeletal muscles. And functional defect will also be there in these receptors. So, this causes a flattening of the postsynaptic folds, and initially acetylcholine release will be normal, and the small end plate potentials which is generated, fails to trigger the muscle's action potential. So, the presynaptic rundown and fatigue is usually manifested here. The main pathogenesis is these antibodies usually block the nicotinic acetylcholine receptors and cause internalization, thus reducing the availability of the receptors in the membrane, and also activation of the complement cascade and destruction of the end plate architecture is seen. And it also causes a widening of the synaptic cleft. This causes the increase in distance of acetylcholine molecules to diffuse from the releasing sites to the receptor sites. And also there can be antibodies to muscle specific tyrosine kinase, which we call as MuSK antibodies. This is non-complement type of binding, and this what does it do is it prevent the interaction of the low density lipoprotein receptor related protein with MuSK, and they disturb the architecture of the neuromuscular junction. The main clinical features, this can be divided according to the symptoms. Initially, it starts with a muscle weakness, like a fluctuating kind of weakness, which worsens as the day progresses. It worsens with the exertion and improves at rest, which is a hallmark of myasthenia gravis. And ocular features, this is the first to manifest usually, like ptosis and diplopia. This can be unilateral or bilateral, symmetrical or asymmetrical presentation. Here, the pupils are always paired, and extraocular muscle involvement occurs in later stages, and it also presents with the nystagmus. Then the involvement of bulbar muscles is also seen, like dysarthria, dysphagia, and chewing difficulties, and nasal regurgitation and nasal twang of voice will be there when it comes to the palatal involvement. In the face, we can see the elevators of angles of mouth being weak, and the levator anguli oris and levator labii superioris involvement. This causes a myasthenic snarl type of feature, and involvement of the limb muscles will be around 15 to 20%, like proximal muscle involvement. For this, we can ask a history of difficulty in climbing stairs and difficulty in lifting the hands up, and the weakness of neck extensors can also be elicited. Then the respiratory muscle involvement and the diaphragm involvement can be seen. For the diaphragm involvement, we can ask for the effort to produce a forceful cough, or inability to project the voice can be asked. Then there can be complaints of mass effect, like the patient cannot lie on the supine position, and if they try to lie on supine position, there also be presence of stridor, and due to the tracheal compression symptoms, and SPC syndrome also can be seen. Uh, then in yeah, aggravating factors can be stress or infection or pregnancy. Surgery itself is an aggravating factor. Other than this, a long exposure to heat or sunlight. Few drugs also aggravates the myasthenia gravis, like calcium channel blockers, beta blockers, and magnesium, phenytoin, and antibiotics like aminoglycosides, erythromycin, clindamycin, and a few antiarrhythmics like quinidine, prokinamide, etc. Can aggravate the myasthenia, and we can classify them according to the different types. Based on the age of onset, this can be a neonatal, or congenital, or juvenile, or adult, or elderly type. In neonatal, this can be either a transient or persistent, which is usually comes from the mother by the transplacental passage. In congenital, here there will be end plate pathology and also a genetic factor, autosomal recessive type of condition, usually in the age group of 0 to 2 years. And in juvenile, the presentation will be in the age group of 2 to 20 years, which is autoimmune in origin. And in adult, the age group of 20 to 40 years, this is also autoimmune with female predominance will be there. And in elderly, which is more than 40 years, the presentation can be seen. Here the male predominance is high, and there can be a seropositive or seronegative type for a nicotinic type of acetylcholine receptor antibodies, and based on the severity and the clinical classification also we can divide. Coming to the Osserman and Jenkins classification based on the clinical presentations, there are 4 classes. Class 1 comes with a description of ocular myasthenia. Here the ocular presentation only comes like ptosis and diplopia. Then class 2 we have a general myasthenia. Here we have 2 classes, 2A and 2B. 2A, this is usually a mild, and other than ocular symptoms, the patients can have symptoms spreading to skeletal and bulbar. Good response to the therapy and low mortality, no respiratory muscle involvement will be seen. In 2B type, this is a moderate type of presentation. Along with 2A, there can be severe skeletal and bulbar muscle weakness. Here the activities of patient is limited, and there can be a fair response to drug therapy. In class 3, which is acute fulminant myasthenia, which is rapid onset of bulbar and skeletal muscles can be seen, and it is onset of symptoms will be severe with the respiratory muscle involvement, and this can progress within 6 months, and it is usually poor response to drugs. These patients have a very limited activity and a low mortality rate. Class 4 can be a late severe myasthenia. Here they develop these type of patients develop severe myasthenia after 2 years of developing class 1 or class 2 type of symptoms, and their poor response to drugs and poor prognosis can be seen. Diagnosis, this can be either clinical, pharmacological, or electrophysiological testing or serological testing. In clinical, here we can monitor the prolonged upward gaze, which will not be holded on by these patients, and holding on outstretched hand like in abduction, and we can determine the vital capacity in these patients. An ice pack test. An ice pack test, the cold ice pack is usually kept over the forehead for 2 minutes, and it is said that the cold can improve the neuromuscular transmission, and the ice pack test can be done. Then the pharmacological, here the tensilon test is done. Hydrophonium, which is a short-acting anticholinesterase inhibitor, is given with a dose of 2 to 8 milligram, which improves the muscle strength, primarily the ocular. If it improves the ocular symptoms after 30 seconds of injection and lasts for 5 minutes, it is positive for tensilon test. And there can be electrophysiological studies can be done with a repetitive nerve stimulation study. Here the stimulation of peripheral nerves up to a supramaximal stimuli of 2 to 4 hertz, 4 times over 2 seconds in TOF patterns can be seen. 10% decrement in the fourth and the first twitch is usually diagnostic of myasthenia, and single fiber electromyography study can also be done. And further, serological testing can also be set to give like anti-acetylcholine receptor antibodies, anti-MuSK antibodies, anti-LRP4 antibodies, which is low density lipoprotein related antibodies can be given. And about the treatment, these patients usually will be on anticholinesterase inhibitors, corticosteroids, and a few immunosuppression drugs. Anticholinesterase inhibitors, mostly these patients will be on pyridoxine, which prolongs the acetylcholine presence at the postsynaptic membrane. And the dose is usually 30 to 120 milligram per day in 3 to 6 divided doses according to their symptoms. The main side effect of this drug is cholinergic crisis, due to the presence of excess acetylcholine at the neuromuscular junction. Further, corticosteroids, these patients will also be on prednisolone with 1 milligram per kg, which can reduce the amount of acetylcholine receptor antibody and reactivities to peripheral blood lymphocytes. And about the immunosuppressants, these patients will be on azathioprine or cyclosporin or mycophenolate mofetil drugs. And further newer drugs like rituximab, cyclophosphamide, and tacrolimus also has been introduced. When these patients are on immunosuppressants, we ideally used to monitor the WBC counts. It should be within a range of 3,000 to 4,000 cells per cubic meter. And the plasmapheresis. The plasmapheresis main thing is it removes the antibodies from the plasma and improves the patient condition. It is only usually short-lived. What they do here is 5 exchanges in 2 weeks, like 2 to 3 liter per exchange can be done. The main thing is this reduces the availability of plasma cholinesterase levels in this, which is also a concern for us. Further, IV immunoglobulins can also be given with a dose of 400 milligram per day, which is 2 milligram per kg for 5 days IV. This can provide a rapid improvement in terms of symptoms. Finally comes the thymectomy. This thymectomy, various approaches have been introduced, like sternal split surgery, sternal split thymectomy, transcervical, video-assisted thymic surgeries, or robotic type. The old one is the sternal split, which requires it's a very invasive procedure. When coming to the post-op recovery and everything, video-assisted and robotic approaches are becoming more popular. We can expect less than 25% of resolution of symptoms after surgery when it is anticholinesterase antibody positive type of myasthenia. This surgery can be, never be done in case of prepubertal children or ocular only symptom presentation type of patients. So, coming to the anesthesia part. Pre-op assessment, as I told, we should elicit all the symptoms and presentations, mainly the duration and severity, pyridostigmine requirement, and recent change in the pyridostigmine doses, which should also be asked to assess the status and severity of myasthenia. If they are very symptomatic, we should think about the need for plasmapheresis also. Respiratory and bulbar involvement should always be elicited. Then coming to the examination, lab part, complete routine blood investigations with concerning thyroid functions, pulmonary function test, ABG, like arterial blood gas analysis, and a serial FVCs can be done for monitoring. CT and MRI thymus can also be asked to look for the extension and invasiveness of the thymic hyperplasia if we suspect. And associated other autoimmune antibodies can also be elicited, like SLE, rheumatoid factors, and everything. Chest X-ray, PA view and lateral view should also be can be asked. And ECGs should be monitored because pyridostigmine itself can induce a bradycardia. Coming to the examination part, airway examination and cardiopulmonary system examination should be given importance, especially the patient is able to lie flat, the stridor and the tracheal deviation. CNS examination of all 4 limbs should be checked properly. Then pre-op, we need to admit the patient 24 hours before surgery while the patient is in remission. Further, since it is an elective surgery, we can also recommend on the physiotherapies and deep breathing exercise, lung expansion manuals like deep breathing exercise and incentive spiros. They should be scheduled as a first case on the day of surgery. And we need to discuss the need for post-op ventilation and explain the post-op plan and the need for ventilation in case of any emergencies due to their disease implications are our anesthesia drugs. Then we can continue the pyridostigmine, steroids, and we can also give an anti-aspiration prophylaxis. Anti-anxiety drugs like benzodiazepines can be given. Uh, and we can come down on the opioids because this can reduce the respiratory depression. Main indications for the thymectomy is to generalize, if it is a generalized myasthenia or any thymic cyst or thymoma, which can, and if this thymectomy can induce remission kind of thing. Uh, For thymectomy, when this patients, myasthenia patients itself get admitted for any other surgeries, we need to prefer on the regionals more than on the general anesthesia. Since it is a thymectomy surgery, we need to combine both regionals and general anesthesia here. I'll go with the combination of propofol, induction of with propofol and remifentanil with oxygen and nitrous combination. Here the volatiles actually can interrupt with the neuromuscular transmission. We can spray on the spray local anesthetics on the vocal cords, which can reduce the response to tracheal intubation. Uh, uh, we need to use 10 to 25% of ED95 when it comes to intermediate muscle relaxants, like for the Vecronium, what we give is a 0.1 milligram per kg. The ED95 will be 0.05 milligram per kg with a maintenance of 1 milligram. Then Attrac 0.5 milligram per kg IV. We can the ED95 will be 0.2 milligram per kg. For the maintenance dose, we can go for a 5 milligram doses. Yeah. Coming to the succinylcholine, succinylcholine has a variable response. If the patient is on anticholinesterase drugs, choline resistance usually occurs as reduced number of functional acetylcholine receptors will be there at the neuromuscular junction. So in these patients who are not on anticholinesterase drugs, ED95 of succinylcholine will be 2.6 times the normal dose. If the patient is on anticholinesterase drugs, plasmacholinesterase activity actually comes down. So, choline metabolism is reduced. So, more succinylcholine can be reaches the motor end plate, and the duration of choline in these type of patients will be around 80 to 90 minutes. When the patient is on plasmapheresis and we administer choline, the plasmacholinesterase level will be already reduced in these plasmapheresis patients, and the duration of choline in these patients will be prolonged as there is no esterase levels. And formation of phase 2 block can also be expected in these patients. These patients are extremely sensitive to non-depolarizing muscle relaxants. Hence, we can opt for the Vecronium or Atracurium type of drugs. And we need to avoid long-acting non-depolarizing muscle relaxants. Mivacurium, better not to use them. Initial doses can be initial dose of relaxants can be reduced to 10 to 20%. Okay. Then about the monitoring, routine monitoring with pulse ox, BP, ECG, temperature, urine output can be done. Along with that, neuromuscular monitoring can also be done. Further, um, uh, thoracic epidural can be placed if it is an open type of procedure, and an arterial line can be placed to check for the beat to beat variabilities. And we can go for a left-sided double lumen tube, and we can confirm with a bronchoscopy. And for the maintenance, either IV, either TIVA or the inhalationals, both can be used. Studies shown that both are, both are good. Dexmed can be better avoided because it can attenuate the vagal activity due to the pyridoxine, and reported cases of asystole is seen. And when coming to the local anesthetics, we can go for the amide type of local anesthetics than going with the ester type of local anesthetics due to the less availability of plasmacholinesterase. Then coming to the video assisted or robot assisted method, lung isolation method, and CO2 insufflation will be. So we need to maintain on the normocapnia levels, and the positioning for the minimally invasive surgeries is also a bit like left late 30-degree right up kind of position. So the chance of migration of tube can also be there. So we can go with the small size tubes. And after this minimally invasive type of surgeries, we can go on the erector spinae blocks or serratus anterior plane type of blocks. Um, Other than that, uh, few note on surgery, sir. If it is a median sternotomy type of surgery, the position will be a supine position. Here, this will be in a vertical sternotomy. There will be stripping on the mediasternal pleura and access into the anterior mediastinum. So the borders of dissection will be superiorly thoracic inlet and the innominate veins, inferiorly diaphragm and laterally the phrenic nerves. So the chance of phrenic nerve injury in the open procedures is a bit high. What they remove is the whole thymus along with some mediastinal fat. Surrounding tissues is also removed. Then they close the sternum with the wires and the primary closure. This comes with type of open surgeries. Coming to the video assisted type, this is a kind of a right lateral position, 30-degree decubitus position. Mostly the scopy will be on the right side scopy because the approach will be good. The right side approach is good because the thoracic inlet access to the thymic veins as they drain into innominate vein can be easily visible. And for assessing into mediastinum through the right chest, there will be 3 trocars in the submammary fold when it comes to video assisted thymectomies. In robotic type, the position will also be on the supine with the right side elevated using the blankets. In robotics, we have a 3-port. 2 ports at the 5th intercostal space and 1 port at the 3rd intercostal space. One for the camera, the other 2 for the robotic arms, with some assistant ports if required. Yeah, main complication in thymectomy surgery itself is bleeding, and the vessel injury, chance of injury into the vessel is high because the invasiveness of thymic hyperplasia into the great vessels can be there. Then a chance of pneumothorax is high, chylothorax, and pericardial injury and phrenic nerve injury can be expected in thymus patients. Then coming to the extubation, the procedure itself was around 2 hours. Expected blood loss can be around 200 to 300 ml. Then extubation the patient should fit into an extubation criteria, and the patient should generate negative inspiratory pressures of more than -20 centimeter of water, and the forced vital capacity of more than 15 ml per kg, sustained head lift for more than 5 seconds, normocapnia, adequate oxygenation should be checked. Then since it is better to go for a atracurium as a atracurium because the reversal drugs can itself cause a cholinergic crisis. Oh, I should have said that earlier. Coming to the post-op monitoring, vitals monitoring should be done along with the temperature monitoring. Further, coming to the pain control, we can go on the multimodal approach, either the regionals, either the regional anesthesia method or the opioids. Then lung expansion maneuvers like the chest physio, CPAP or BiPAP can be given. Further aspiration prophylaxis should be added. Coming to ventilation, there is a criteria called Leventhal scoring criteria. If the duration of myasthenia is for more than 6 years, or history of COPD or pyridostigmine requirement is of more than 750 milligram per day, and the vital capacity of less than 2.9 liters, these are the parameters, and scoring is there according to that. If the score is fits more than 12, the need for post-op ventilation will be high in these type of patients. So assessing this, we can plan on the ventilation. Then checks. Then coming to the cholinergic crisis and myasthenic crisis. Cholinergic crisis mainly due to the acetylcholinesterase inhibitor overdoses. The main feature will be salivation, bradycardia, bronchospasm or sweating, increase in secretions. Meiosis presentation will be there here. Here the patient will not have improvement with the tensilon test, like 10 milligrams of hydrophonium given. The treatment is we need to withhold on the anticholinesterase, and we can administer atropine with the dose of 0.4 to 2 milligram IV or a glycopyrrolate of 0.2 to 1 milligram. And ventilation, mechanical ventilation can be opted if the patient is not getting settled. In myasthenic crisis, this is due to the underdosage of acetylcholinesterase inhibitors. The presentation mainly will be hypercarbia and mydriasis. There it is meiosis, here it is mydriasis. This improves with the tensilon test with the hydrophonium of 10 milligram given. The treatment is giving an extra dose of anticholinesterase or IV immunoglobulins or plasmapheresis can be given. That's also.
Very good. Were you reading it from your notes or you were trying it export from your mail?
Sir?
Were you reading the answer from the prepared notes or were you enumerating everything from your memory?
There are few things and few points I could recall from.
Very good. Excellent. Very nice, elaborate preparation. It has taken almost 26 minutes for you to complete orally. Okay. So this much of information is not needed when you are asked the question in your theory exam. And you can't write this much. It will take at least 45 minutes to 1 hour to write if you want to write everything. Of course, Myasthenia gravis is a very, very rare entity. I have had only 2 cases in my career. One of the case for thymectomy with severe myasthenia gravis. Otherwise, it is milder forms are of course there. There is slight weakness of the ocular muscles will be there, but the bulbar weakness muscles where there is difficulty in swallowing and aspiration, inadequate breathing. That sort of cases are quite rare to see. But they say that all myasthenic patients, almost about 70% of the patients diagnosed with myasthenia might have suffered from myasthenic crisis at least once in their lifetime. Because of limiting the doses, they because of the drugs. And so you have to cut short your answer to minimize the presentation. And from anesthetic point of view, we want to know only 3 things in a myasthenic patient. One is, do the patient belong to the category where thymectomy will be helpful in remission or curing this particular problem. And as you said, it is the 40 to above female patients with who are autoimmune positive, who have a identifiable myasthenic thymic swelling or thymic enlargement seen into MRI of the chest or CT chest. They are the ones who will definitely benefit. Not all myasthenia patients are going to come for thymectomy. Please remember that. Only a category of patients, especially the female patients belonging to 40 and above, who will require thymectomy if they have an identifiable thymus mark. And second thing is we must make sure that they don't have bulbar involvement before surgery. That it's schooling in the parents not able to swallow or getting aspirated repeatedly, developing precipitation, getting admitted on and off with the because of the so that category poses a really great challenge to you. So you have to optimize them well before as by your other methods of additional drugs like steroids and modulators like purchase or tacrolimus and even cyclosporine or go for this plasma steroids is not plasma phoresis. Usually that's plasma phoresis is and where the antibodies can be removed. That may be a temporary relief from this. And the third important point is, are you going to plan for elective ventilation of these patients after the surgery, or is it safe to extubate these patients on the bed? Okay, so these three questions have to be uh, emphasized in your answers. One, whether thymotomy is helpful. Does the patient belong to the category where thymotomy is helpful? Second, does the patient have a bulbar lack of following and big aspiration in respiratory insufficiency opportunity. Third, what is your plan for post-op intervention? These 3 points have to be in. And once you do the routine investigations and respiration and post-op for surgery, you have usually explained all the various types of surgical approach available, right from the oldest anatomy to the newest particular everything. But in your answer of management of this patient, you must first say preoperative evaluation, investigation, then pre-anesthetic instructions to continue with the oral anticonceptive drugs, what time we will give, and then intraoperative management. There you must emphasize more on the relaxant part of it. That is what is the expected of the you from the the relaxants, the patient with myasthenia is like a neonate. They are resistant to depolarizers and they are resistant to depolarizers and they are very sensitive to non-depolarizing. So if you use non-depolarizing relaxant, they will have very prolonged duration of action. Whereas for the depolarizing dexamethasone, we require a larger dose to intubate. So most of the books as well as practice, what they advocate is avoid usage of any type of muscle relaxant, right from for intubation to maintenance, you avoid. So patients who have severe degree of muscle weakness because of myasthenia, once you do the induction and make them unconscious, their respiratory effects will become very poor. And you can easily put a laryngoscope, visualize the cord, spray the whole cord and the upper trachea with both of them again, and intubate easily without causing any hemodynamic response or bucking and coughing or holding and spasming. Nothing will happen. They will be, the open will be very wide open and you can easily intubate patients who have severe myasthenia. And even for maintenance, you will not require relaxants. But once you use a volatile or you do a continuous distribution of sedating agents, you can override their respiratory efforts and maintain a controlled ventilation without the use of this is what we have seen in the experience. So both for intubation as well as for maintenance, we don't require any relaxation or relaxation at all. If at all surgeon insists that we need a bit of relaxation, so it's very superficial surgery, but in video assisted thrombectomy, they may say can relax the patient. In that situation, the ideal relaxants which can be safely used in these cases timing, you can easily get back the spontaneous respiration without giving a reversal agent like the second relaxant which is located nowadays is rapronate, because we have a relaxant like Sugammadex, which can easily reverse paralysis without causing the risk of cholinergic crisis. We are worried about reversal because it can reduce the excess of acetylcholine accumulation and cause all parasympathetic effects like tachycardia, salivation, all these things can happen. So we don't want to precipitate a cholinergic crisis by giving the reversal. So that is the second important okay. The third point is for all types of surgeries, whether it is sternotomy or whether it is colonoscopy, by any approach, either transcervical or sternum, subsequent approach is also there. So for all these things, they advocate thoracic epidural as a mainstay, which will take care of the intraoperative pain, and you can use the same thing for postoperative pain, right? Which is very low concentration of total anesthetic. So, ideal technique that is described for thymectomy in a severe case of myasthenia is preoperative. Avoid given the anxiolytic, give a minimum dose of anxiolytic with the patient. HPO, aspiration prophylaxis is must. So you have to give either pantoprazole or ranitidine, and country molar citrate can be given, and then you can induce the patient with propofol or Tomidate, and then intubate the patient without relaxant by spraying the upper airway, either with a regular endotracheal tube or for bronchoscopies, you can use a W tube, ideally a W tube can be placed the topical anesthesia. It's called translaryngeal anesthesia. So that can be sprayed up to the position of transverse on the carina itself, and you can place the tube and proceed with the surgery with either a TIVA or an innovation technique, and can easily control the ventilation with the ventilating setting. A little bit of overriding can easily manage. And at the end of the surgery, depending upon your plan, whether it's plan to electively ventilate the patient or you want to extubate on the table, which by your assessment of the muscle chemistry of the baby, you go ahead and do. If you have planned for elective ventilation, and do not attempt any reversal, even if you are given a relaxant, take the patient to your ICU and ventilate. On the contrary, if you are planning to extubate, wait for the full recovery of muscle power, as you rightly mentioned all the points how to assess the recovery. All these criteria should be taken, and then you have to extubate the patient on the table and take care of it. Okay. So that is the short form of how to answer this question.